Hello, my name is John Cavetto, and I'm going to present my project, Medication Adherence Challenges and Solutions Regarding Medicare Recipients. So, uh, before we started this project, or when we started it, we used this format called the Peacock question, and basically, my question was originally something a bit more complicated, and it felt a bit biased. So I narrowed it down to what are the factors that affect medication adherence in Medicare patients. As you can see in the slide right here, uh, that is my original concept map. So in the center, it says low medication adherence among Medicare Part D recipients. And there were five factors that I assumed. The first being too many medications to keep track of. The second, lack of timely and reliable transportation. The third, some medications require a high copay, making it unaffordable. The fourth, depression about needing to take medications. And the fifth, mistrust of the healthcare system. The clinical question is an important one and is worthy of our time because many patients do not tend to stick to their medication routines. These lapses or stoppages of medication adherences cause undesirable health effects on these patients, which may lead to complications or even death. Therefore, it's important to investigate this. Review and research. Based off the research, the main factors deciding medication adherence are really two things, but there are also sub-values to them. The first major category was socio-demographic factors, two of which I narrowed down through research, would be lack of education on medications and cost. The other big factor would be psychosocial factors, and those are connected to distrust, polypharmacy, and depression. Erickson's theory, integrity versus despair. I used two different theories. One is a psychology theory, and another would be is a nursing theory. The first one is Erickson's, which is a psychology theory. I narrowed it down to integrity versus despair since we are talking about Medicare recipients and they tend to be 65 years and up. Integrity versus despair, Erickson described it as a retrospective accounting of one's life to date, how much one embraces life having been well lived as opposed to regretting missed opportunities. In that context, when we want to screen our patients and interview them, especially the ones who are 65 and up, we tend to look for extroversionness and openness to experience to have an which has an indirect relation to ego integrity that is mediated by well-being. Normally, we don't want to see this, but we should assess for as well. Is neuroticism, which was related to despair and explained the relationship of depressive symptoms related to despair. Gerben et al. 2017. So the linkage between Erickson's theory and the clinical problem is that Erickson's theory shines a light into what stage our patients are in and how we can assess them, and therefore we can customize our care better to their needs. Now we're in Orum's theory. Orum's theory is a nursing theory. Its main three features are self-care, theory of self-care deficit, and theory of nursing system. The linkage between Orum's theory and the clinical problem is really that medication adherence is central to the theory of self-care. They link in instances where it's crucial for the provider to find or assess for the deficits in self-care, namely when a patient has veered from their medication regimen. Orum's theory encourages the nurse to find practical interventions that could help the patient return to their peak function for the advancement of what they call self-care. After the nurse finds these solutions, it's time to implement them and reassess for efficacy. Orum's theory allows for tailor-made care, especially for the patient, and ultimately allows them to achieve their self-care goals. So the appropriateness of the selected theories. So I found it was appropriate to explain and describe and predict this in regards to this clinical phenomenon, medication adherence, and the obstacles to that goal. I feel that it would not have been able to just use one theory, as ORMs would have been sufficient, but I did want to include something more tailored and custom to the geriatric population. I feel that Orms and Erickson's helped me understand the psychological and external variables that affect medication adherence. Therefore, both theories as a package deal were appropriate to use. Although I do wish I have found more on Ericksonian screening measures, I did get a good insight into which behaviors meant which ones meant what. I feel that elderly depression could have been a viable concept to create interventions for, but I felt it would have been too parallel to integrity versus despair. And as far as my interventions go, I did not find conflicting information other than some interventions that seemed a little similar, such as automated messaging intervention. So this is the new concept map. I did change it a bit. So in the middle, the new question would be medication adherence challenges and solutions regarding Medicare recipients. More of a topic. And the five barriers, this time they changed. I changed them to education, cost, depression, distrust, and polypharmacy. What really changed was education, and as far as interventions go, uh, education and cost have the same intervention. Educate patients about medication resources and cost savings opportunity programs. As far as costs, it has two interventions on its own. Collaborate with pharmacy to have meds changed to the generic or to find discounts. The other intervention would be educate about cost savings, such as good RX, cost plus drugs. And for depression, we assess using Ericksonian theory, integrity versus despair, and employ MI, motivational interviewing techniques about medication adherence. As far as polypharmacy goes, we will be collaborating with pharmacy to simplify medication regimens, as well as provide pill boxes for seniors to keep track of their medications as well. And in order to solve the distrust issue, we must build trust through meaningful collaborations. We must create professional relationships as well as listen to our patients when they communicate with us. So that was the map. The greatest aha moment, which linked the clinical question concepts, theory, and implementation strategies, is that they're simple and cost effective. I was almost expecting like a big, to do with interventions, but to be honest, it is better this way as it would be the more affordable way and easier way to do this. And I think it's pretty great. Um, what I would want my peers to take away from this presentation is that we have to look at the whole individual when assessing for these types of issues. I don't think it's going to be as apparent as we may think. So a lot of the time, the patients, yes, they're doctors and they're nurse practitioners, and I think what we could put into practice is just employing these interventions as well as assessing, because the first intervention that we must always do is assess and figure out what's going on first. So, thank you very much. And this is my references sheet.